institution is hosting the live surgery for surgeons at 2 centers, which has never happened before actually in our surgeons. Rajesh, I don't remember. Do you remember? We've not done it before.
No. It has never happened before.
Yeah, it's a great idea. And the surgeries are also really varied and different. So we saw phacoemulsification with toric lens, with synergy lens, and now we are going to also see the other kinds of surgeries other than phacoemulsification from the other center. So I think that was
Dr. Aditya, can you hear us?
Yes. I don't know if
we can also hear you. Yeah, great.
Okay. So this is a 65-year-old lady. She's come with a history of decreased vision in her left eye, and she has got grade 2 nuclear sclerosis with macular hole. So we are going to do a combined phaco-vitrectomy for her. I've already done the capsular excision and HITO dissection so as to save time.
Okay. So perfect. I think we've never had a demonstration of macular hole on a surgeonar again. And it's
that too combination of
it's going to be great to see both together. Something which people don't get to see, and that too unedited in its real life form, and that too from the comfort zone of our own laptops and our own homes. So thank you, Aditya, for doing this.
Thank you, madam, for this opportunity. So I'm halfway through with this nucleus removal.
So for retina surgeons like you, this cataract surgery must be hardly anything. It must be, just one small thing in that big surgery that you are going to do.
Actually, both of them are athletes, no? So they run, they push the nucleus also to run away.
So as long as it runs away, outside is good. When it runs inside, it's always a difficult game. For a retina surgeon also to have that situation, I'm sure sometimes you miss your beats.
Yeah.
But great transmission. I mean, very nice microscope. You can see just about everything, every single vessel, every single, every single thing is very nicely focused. So, Aditya, you've not learned to do bimanual from the main wound and side wound from Zai. You made 2 side posts for yourself.
That is something that is unique to her, I think. So, I'll let her do that way.
So when you do a combined surgery, cataract surgery and macular hole surgery, do you like to combine it at the same sitting, or do you like to sequentially put it first?
No, I combine it. I usually combine the cataract with vitrectomies, especially if the age group is more than 50 years or 55 years. That makes it easy for us to even visualize the peripheral parts of the retina.
Okay, so you must be putting sutures, right?
Suture, it depends. I mean, now if you see my incision is 2.2 millimeters.
Yeah.
And it is almost 1.5 millimeters long. So usually I don't need sutures for this type of long incision.
Yeah, long tunnel you can manage without.
इसका थोड़ा लग रहा है इसको है ना
What is the preoperative vision of the patient? I mean, at what level do we normally would
so she's 6/60 in her left eye and she's 6/12 in her right eye.
Okay.
So I do expect some zonular dehiscence here. So I'm going to use a CTR before I remove this cortical matter.
Okay, perfect. I think inadvertently we've seen small pupil phacos and this TPR implantation, which is again going to be very useful for people who are, wanting to see how it is done.
What's the cause of macular hole in this case?
Age related. But I really don't know the cause of zonular dialysis in this case.
Yeah, that's why I was thinking that maybe it's a traumatic, then maybe that's the reason for zonular dehiscence.
Possible, I think, but there's no history of trauma. So I'm just inflating the bag, making sure that I visualize the anterior capsular excess margin here.
Yeah.
McPherson देना दूसरा.
So Rajesh, there are two. There's yet another model also which is there which can be injected. I haven't used it. You have the experience of using the one with
The preloaded ones.
yeah.
Yeah. It's very easy to insert. Obviously, the cost is more.
But this also looks very easy. And
Yeah. It is also very easy. But in that, you just have to go till the bag and then you can easily inject. So I mean, both are doable and both are easily done, but that is easier, I would say. Definitely there's a cost for it. So
there are now companies, Indian companies also who are manufacturing the
yes.
From Adu, I think, with no financial interest in it, but
So I've stabilized the bag using the CTR. I'll take care of the cortex now. Hopefully the bag shouldn't trouble us now.
I think when you place the CTR, the cortical matter becomes a little tricky to aspirate, but because you're using a bimanual, I don't think that really should be a problem.
That too, if there's a tangential pull the way he's doing, he pulls tangentially, then it is pulled easy. In a radial pull, it can create problems, but in a tangential pull, it helps.
So first I'm removing the cortex which is in the area away from the dialysis.
Yeah.
And then I will put some viscoelastic underneath this area of concern.
Yes, that's
and then I will try to aspirate the lens matter. Sometimes even I use a intraocular lens inside so that this cortex becomes easier to remove without damaging the zonules further. So I will give an attempt of removal of the cortex now, and if it doesn't come out, I'll place the intraocular lens first and then take care of the cortex later. Okay, Visco. I will place the lens in first. So I will be placing the lens first and then removing the cortex later, because this lens haptic will also serve as an additional
counter support kind of.
Yeah, support to the back, and then the cortical matter should come off.
Yeah.
So this is which lens again? Is it Tecnis?
Yes, this is a Eyhance lens which I commonly use for combined surgeries, phaco-vitrectomies. And I'll make sure that this haptic goes inside under the cortex.
Yeah.
Let's go. All right, so now I have the lens inside. I will use this dry aspiration, sometimes also works well for removal of this cortex.
So Rajesh, you were talking about a suture to be placed, and I do remember remember that some of the retinal surgeons, even in our place, they like to put a suture there and then do a vitreoretina surgery or a macular hole surgery. So what are your thoughts on it?
Yeah, I mean that is something which is usually practiced. But what he has done is he has made a long tunnel.
Yeah, so probably we wouldn't.
It will have a better valve effect once he tightens the anterior chamber. So I mean, if one can do that, that is definitely very good.
Because I remember some of the sequentials that we do for our retina colleagues, they insist, that when we do cataract surgery,
that's why I asked this thing.
Yeah, you please put one suture, and sometimes they say you put two sutures, and they like to take the case maybe the next day or maybe in 2-3 days.
Yeah.
But I think this is also this is the advantage of, I think, being the retina and cataract surgeon both.
True.
So I've been able to remove most of the cortex. There is a small cortical matter left down at 6 o'clock.
Yeah.
I will not be very fussy about removing it. I will see if it comes off in one go. Otherwise, I would be happy to leave it there. Yeah. So looks good.
Yeah.
Yeah.
So now we'll go on to proceed to doing a vitrectomy. I will be doing a 25 gauge vitrectomy here. I'm not going to remove the viscoelastic from the anterior chamber right now, because as you know, there is a zonular dialysis. When I do a fluid air exchange, I may have a situation where the air keeps coming into the anterior chamber. So I will like to leave it there at the moment. And at the end of the surgery, if I can just tap a little bit onto the anterior chamber, make sure that there's no intraocular pressure rise. All right, so we are ready with the vitrectomy now. दुखता है? ठीक है, आता अपन थोड़ा सा इंजेक्शन देते हैं ना.
The sutureless vitrectomy is the 25 gauge, the 27 gauge, 23 gauge. These all have made life much
easy, absolutely
easier for retina surgeons.
Also, another care that I will be taking when I am doing the vitrectomy is not to do very close vitrectomy close to the posterior capsule now, because as you know, there is a zonular weakness there. So if I try to be too close to the posterior capsule, I might end up damaging the zonules more.
True. Now, a few years back, we could not have imagined that we can have a live surgical demonstration of retinal surgeries, but things have advanced so well that.
Indeed. Another precaution that I will be taking now is many a times the viscoelastic falls onto the posterior pole and it doesn't let the macula stain as good as it should.
Okay.
So right now I am doing a vitrectomy. Generally I would be little anterior first and then going back. But here I am slightly in the mid-vitreous to begin with. Just to make sure that I don't damage the zonules further. This is a stage 4 macular hole, so the PVD is already induced.
Yeah.
But I will obviously stain and check it once more.
So which stain will you use?
Brilliant blue.
So everything is very beautiful.
I'm just going close to the macular area, making sure all the viscoelastic is also aspirated.
We can see it very clearly.
Very clearly, yes.
This looks clean. So now we'll put in tricot and check if I have any posterior vitreous attached to the disc. थोड़ा इसको डालना हो कॉर्नर पे. Okay. Yeah, so there is a bit of posterior vitreous for us to induce PVD. Looks like.
Yeah.
That's the great advantage, I think. All retina surgeons are fond of using the various dyes, such as this tricot, brilliant blue. It definitely aids in visualization of the retina and the membranes. And in this case, the adherence, I mean, whether the posterior vitreous detachment is there or not, is easily visible now, thanks to the tricot. So what I do generally is create a small opening in the area near the equator, as you can see.
Yeah.
Anterior and the posterior vitreous is now separated. So this bowl of posterior vitreous attachments slowly and slowly, it's like a hydrodissection happens.
Yeah.
So similarly, a hydrodissection of this posterior vitreous will start happening, and that will allow us to do the PVD induction in an easier fashion. So once I have this opening made, slowly some amount of saline will keep flowing under the posterior vitreous, making PVD induction a bit easier.
Yeah, that will ease out. Beautiful. The view of posterior vitreous detachment is such a magnificent view, no?
Absolutely.
It gives so much of pleasure.
Absolutely. I would also consider this step as one of the rate limiting steps of a fellows in training. Once they achieve the step of inducing the PVD, I think the rest of the training starts going easier.
True, very true.
So we are doing a macular hole surgery here, so there is not much importance of vitreous base shaving in these cases. Of course, we must check the periphery in detail before we close the case. But here I am making sure that the posterior vitreous is detached and most of the cortex which is visible is removed before I stain the ILM with brilliant blue dye.
What's the setting of this of the vitrectomy cut rate?
Yeah, so I am using 7500 and cut rate, and the vacuum is 450. 7500 and 450.
Wonderful.
All right. Yeah. So I'll just show you, if possible, a view of intraoperative OCT.
Okay.
I don't know if you are able to see it on the screen.
I think they'll have to show on the monitor.
On the monitor, yeah.
Yeah.
वो monitor turn करके दिखाना.
External से monitor turn करके दिखाएंगे तो I think we will be able to see. Please focus on the monitor.
Yes, yes.
The view from the microscope is actually beautiful. We can see really very nicely. There, the microscope is really very good.
Clean करो ना lens.
Okay, we can see now the intrapository microscope also. I think we need to focus a little bit.
Yeah, correct. I'll do that.
So you've been using this intrapository microscope for how long now?
Yeah, I've been using this for now almost 2 years.
Yeah.
You can see the macular hole now?
Yeah, we can
Yeah,
see.
we can see.
We can see very well.
Okay. So I've been using it for last 2 years. I find it quite useful, especially in cases of epiretinal membranes, and also in some cases where I've used it in patients where silicone oil was removed and the retina had a particular tinge of white due to long-standing detachment. So to confirm whether the retina is attached or detached, I used this intraopacity. Apart from some submacular surgeries where submacular blood was
Okay.
taken care of using RTPA
Yeah.
injection. Hydrocannula. So as we keep injecting these external fluids inside the vitreous cavity, the intraocular pressure goes up, and I use this hydrocannula just to drain the excess fluid. गोळा नाही कमी आता मी इंजेक्शन सुद्धा दिलंय. So now you can see that the disc pulsations have stopped and the dye will take its own action. For about 1 minute we'll hold on. In the meantime, the patient has a little bit of pain, so I will top up the anesthesia. And some more visco will be used in the anterior chamber. So the good thing is that the lens is quite stable now. And
The lens looks absolutely stable.
the caruncular block that I use for patients where if I have to top up any anesthesia near the medial canthus.
So earlier also in the, before you started the surgery, it was what kind of block was given?
What kind of?
Like, was it only?
So xylocaine and Sensorgain. So I use about 4 to 5 cc.
And the same way, caruncular?
Yeah. Same.
Okay.
But the amount is much less when I give the caruncular block.
Yeah.
It's about 2 ml to 3 ml as against what I gave initially was about 8. I'm just waiting for the dye to work. Now it's already 1 minute over, so we'll go back and see.
So basically you are waiting so that it should stain. That is why. Okay.
So now I'll just go back and see if the staining is adequate. Looks okay.
Yeah.
So what I'm aiming in this case, because the macular hole size is quite big, I'm aiming to do inverted flap here. So our usual trick is to put PFCL on the posterior pole and then keep making a small circle of macular axis so as to fold these edges inside and then extend the axis later on in the second stage. So I will do 2 concentric macular axis. So the pressure goes up. I will use hydrocannula through the same incision and drain some fluid out and then reintroduce again PFCL. So it's like doing a paracentesis using 26 gauge cannula. So now once the pulsations stop, I will reintroduce the PFCL. It is important that I have a uniform one single bubble. Otherwise, these small fish eggs are very difficult to remove later.
True. That's why you went at the edge of the previous bubble and then.
Yes, yes, sir. Just reducing the pressure again so that I can inject a little bit more of PFCL. We'll have to change the cutter. So it's just enough to cover the posterior pole. Once again, we have this IOP going up, obviously because of the PFCL bubble. I'm putting in 26 gauge cannula inside the vitreous cavity so as to allow some more fluid to escape. Now this happens usually because of the valved cannulas that you use, so there is no efflux of the fluid.
True.
And so this maneuver, although it takes a little while, it's still worth it because we don't want to compromise on the circulation of the optic nerve.
Yeah.
So as you can see, optic nerve has returned back to its normal color.
Yes.
And I will reintroduce a little bit of PFCL and then we will start the ILM peel. It should be good, right?
And with what instrument you would like to do the ILM peeling?
So I initiate my peel using the diamond dusted membrane scraper, and then I use the ILM peeling forceps.
Okay. Nice.
So this becomes traumatic.
Absolutely.
And I'm going to make these 3 or 4 small cuts on the ILM.
Okay.
So that these will become the inverted flaps under the PFCL. And because there is PFCL bubble and these small flaps, due to the capillary action, will get sucked into the macular hole. So there's no trauma involved in this.
Absolutely. It's looking absolutely atraumatic.
So I just leave it there and it automatically falls inside the macular hole.
Very nice.
So this is already covered. I don't have to do too much into it. And now I will make a second round. This will be for extending this macular peeling into a larger circle. So the inverted flap has happened without any trauma, and hopefully I'll do the same for the remaining ILM peel. So now I have to only enlarge this.
Yeah. So once you have done this stopping into the macular hole, which gets closed, then what is the additional advantage of doing this removal
So
of?
it acts like a scaffold basically for the migration of the retinal tissue and aids in healing, aids in getting
No. That is absolutely right. The removal from arcade to arcade.
Okay. Yeah. As you said, yeah, what you say is right. I think maybe we need not do all this much. But as traditional teaching has been to go right up to the arcade, so.
The ones that have gone into the macular hole have been very nicely sucked into.
Yeah, the only thing is, maybe the point to consider is sometimes when we do the fluid air exchange, this flap which we have put in the macular hole comes off.
Yeah. So what precaution one can take or what steps one can take?
Yeah. So I will try to show you the way how we do it. First is I will make sure that the cannula is pointed in a nasal side.
Yeah.
And when I do the exchange, I'm very gentle about it. I'm not very aggressive in rapid removal of the PFCL. And also I will do a PFCL air exchange. So automatically it's more like a double sandwich of PFCL and air pressure that keeps this flap in place. I'm just completing the small residual fibers that I see. Just fashioning them out. That's all. So I believe we have a sufficient peeling here.
Absolutely. It's on up to one arcade. It's done. The second side are completing.
Yes. So I've just removed it. I think this should be more than sufficient.
Yeah.
So what I do now is, okay, I'll check if I can demonstrate one good quick OCT. I'll try to show if we can probably focus a good OCT here. So you can see probably the macular hole and the inverted flap inside.
Yes.
Okay.
I think.
Yes. Now it's. Yes. Yeah.
So now I will switch to fluid air exchange. So I am on IOP 30.
Okay.
Because
the air PFCL exchange, right?
Yes. So now I'm doing air PFCL exchange. I'm making sure that I don't increase the IOP to 60 because I don't want air to come into the anterior chamber.
Okay.
Because of the zonular weakness that we have noted operatively. And how do I know whether the fluid has been removed completely? You can see this cutter is going down. It's in the fluid area. This is the air area. And so now there is a small transition zone. So I will go to the edge of this PFCL bubble and aspirate the remaining fluid.
Okay.
So that when I'm closer to the disc, I will not be in a situation where only fluid will keep coming out. So I will have removed most of the fluid. It's in the fluid area. This is the air area. So as you can see, the air has reached the border of the PFCL now. Okay.
Yeah,
and
we can see that.
My cutter will be facing superiorly, or I mean inferiorly or nasally. so that I don't have
Okay.
PFCL flap. ILM flap.
Dislodge the flaps.
And I'm very slow now. I'm not very fast in rapidly removing this PFCL. I'm taking time purposely to make sure that the flap doesn't come out.
Yeah.
In spite of all these precautions, once in a while you will end up with a flap which comes out.
True.
But that's fine. Hello, Nakaji.
I think most of it is out now.
So as you can see, all the air is exchanged.
Yeah.
There is no fluid left, and the flaps are very much in position. All right then. So
yes, the flaps are very much in position.
So a quick scan of the peripheral retina.
Yeah.
To make sure there are no inadvertent breaks. I am not going to indent now, obviously.
No. Yeah. But with the wide angle, most of the things are visible.
Yeah, correct. So with the wide angle, it's easy to see all the periphery. So I think it's all dried up. I don't have to be more invasive. And I'll be using SF6 gas, 20%.
Mm-hmm.
Thankfully, the zonules have behaved and they did not let the air slip into the anterior chamber.
Absolutely. Lens also nicely inside the retinas, we can see clearly.
Yeah. So now this SF6 has been connected. I am putting one cannula through the superonasal port so as to allow the gas exchange happening. Keep injecting. So I use a 50cc syringe.
Okay.
Resistance I have to bolna. And I do 20% SF6 gas injection.
Mm-hmm.
And I'm again very gentle because I don't want any pressure on the zonules here. So slowly exchanging the fluid, the air with gas. So now 30 cc is over. Now you can see it's 20, going to 10. And once I have a resistance, then we stop and pull off these no. So the check of the pressure looks good. And that's the end of the surgery.
Wonderful.
Thank you.
That was a wonderful demonstration of, macular hole surgery, as well as every step was very methodically and very properly demonstrated. I mean, a person who is, just learning retinal surgery will learn a lot from such a wonderful demonstration, because every step was very, very nicely shown, very nicely.
Thank you. Oh. Thank you. Thank you.